So we're going to take a couple minutes. I'm going to open the mic to everybody, but Dr. Miran, do you want to start off? Do you have some questions for either Parth or Shari that might get us going?
I guess I would ask to what extent you think the resources and expertise at individual institutions should drive the choice of therapies in this small subgroup of patients who have refractory shock and need some type of an advanced intervention.
I think that just goes back to the following talks that you're going to have, the need whether we should have Parth or not. I think at least I'm setting up a stage for you. So I think all the hospitals have a well-established shock team, and I think we just which involves our cardiac surgeons, and they're not 30 minutes or sitting at home. There is person at in-house. So shock team existed at a major tertiary care centers, and our Parth team is a perfect bridge to a shock team. So every time we have a patient with a massive PE and a cardiac arrest or an absolute contraindication to the TPA, we just get together and we make a real life decisions. And some of the things that Shari mentioned in terms of anticoagulation, right? So yes, you talk about empiric anticoagulation. We are talking about when we put an patients on ECMO, we bolus them with heparin. So we are with you on that, right? You talk about surgical embolectomy, you put people on heart-lung machine. We are just instituting that heart-lung machine at bedside so that you don't have to cannulate the aorta and the IBC under direct surgical vision. So we are with you on that. So I think a lot of concepts that we have learned from early anticoagulation, then she mentioned about TPA use. I'm with you on all of them. Let me point out two other questions that she raised about guideline recommendation. I don't even think that ACCP guidelines even touch, or they didn't even have enough evidence to touch about ECMO. American Heart Association ACLS algorithm gives a 3B recommendation for push dose TPA. So I think it's a very gray zone, and I understand that the bleeding happens with ECMO also, and also TPA. It's a collateral damage, but we are talking about a very sick group of patients who have unexpectedly unacceptable high mortality state that we are dealing with here. So that's what I would say. Thank you for bringing up the question.
Up on similar points, I think that the time of cannulation does matter a lot. Most institutions, while time to cannulation can vary a lot, I think that time to TPA does not vary as much. And so if we're talking about time being the biggest driver factor, then giving anticoagulation and giving thrombolytics, and especially because Dr. Rali brings up the point that they're not contraindications to each other. So you might as well give the TPA and see if that works. And if you're in the 10% of failure of the TPA, then maybe consider salvage ECMO.
I think one thing I would add to that, which is kind of interesting, which we see in real life, unfortunately, when you have a cardiac arrest, sometimes there is no history there, right? Patient doesn't tell you that you have a PE also. So you're talking about giving a PE sometimes in a cardiac arrest situation when RV is dilated, and patient may have a stroke a month ago. Who knows that? So I think sometimes, yes, TPA sounds simple enough, but think about the patient. You're not even made a diagnosis, and you're pushing them a dose of TPA, a push dose TPA, which is not weight-based. Unfortunately, we have never studied or we never identified that in the stroke patients, they get TPA based on their weight. Here, a 40-kilogram person gets the same dose of TPA, so is 140 kilogram, and you expect it to work like a magic? Maybe it is. So I think the dose is something that we don't know, and patients may or may not have a PE, they just have a cardiac arrest. ECMO gives you that opportunity to take back and sit back and think about it. So I think point is well taken, but yes, there is a place for that.
You can also do point of care ultrasound directed TPA dosage and keep on seeing if your RV starts recovering with it. So you can change your TPA dosage. You have privilege to give more TPA if you think there was worthwhile. And I would say that your outcome benefits are similar in the same groups. The mortality is the same, driven by age. If people got ROSC, meaning they probably had a smaller clot, then they did better with ECMO. So if you were probably able to dissolve those the same. Similarly, the demographics that do fine with ECMO are the same demographics that did okay with TPA.
Yeah, I think I'll just answer this question with that push dose TPA. There is one paper that I have seen in last 10 conferences, 10 years of conference from a medical student till I'm an attending. There's only one Sharifi paper which keeps on talking about that 90% survival with push dose TPA versus with, at least with ECMO, we have been able to do a systemic review on a topic. So at least I would say that I don't think there's any more push dose TPA coming out. And it's one paper that we are basing our argument against versus at least we are at a position where there is not only one systemic review, but multiple systemic reviews based on small studies which way outpace the benefits. So if you talk about evidence between two low quality evidence, I think we have a little bit more evidence on ECMO side than the other side. So.
Well, thank you.
I have one last question for Dr. Rali. To what extent do you see the application of ECMO to those high severity PE patients as a bridge to embolectomy versus as an end unto itself?
I think 50%. I think in last 1 year at our center, we just recently analyzed our data. We had used ECMO in 14 patients, and 7 of them went needing some form of percutaneous or surgical embolectomy, and the rest 7 were just maintained on ECMO itself. One thing we also noticed that once you place them on ECMO, and if the RV starts to recover, as Shari pointed out clearly that it starts to recover very immediately, you would see a signs of improved perfusion within next 2 or 3 days. So even if we are talking about as a bridge to some form of treatment, we always give them 48 to 72 hours to see how RV is recovering. And if RV is recovering, rule of thumb is do no more harm. And we do not offer them aggressive treatment, maybe percutaneous, surgical, or catheter-directed treatment, and work towards weaning the ECMO support. And we still have great pressors like dobutamine and Liverfed and other support to wean our ECMO stuff. And so I think it gives us time and setback and more time to offer a definitive treatment.
All right. Well, I think you both did a wonderful job. And as happens in many of these debates, I think that there's certainly a role for at least consideration of many of these advanced therapies. And I'm sure that at least what I heard was there's a lot of common agreement too in terms of, as you mentioned, time to treatment, time to anticoagulation, and that we are talking about a group of patients that are at least, as you said, intermediate high, if not high risk.